We're here with Bob Grant, who has been cutely called, you called yourself the father of, the midwife, the father of PrEP, but most people call you now, or you want to be called the midwife of PrEP, which is interesting. But you are from Gladstone Institute, and you have been here at the conference talking about the 067, of which there are a number of your colleagues who are also doing presentations on 067. And I think before we go any further, let's tell our audience what 067 is.
So the HB10 067 study, which was also called the ADAPT study, was a study to see whether daily or non-daily PrEP was preferred among African women or men who have sex with men and trans women in Bangkok and New York. We really know that anything that we can offer in medicine works best if people can adapt it to their lives and to their complex living situations. And that is very true for sexual health. You know, we really need technology, we need biomedical approaches that people can use and adapt for themselves. And so our goal was to see whether daily or non-daily use of PrEP was more or less attractive to people.
And the interesting thing is you could evaluate that by geographic region, because there may be a cultural or social implication that may cause them to be more interested in one way or the other. And what was the simple outcome of that?
Well, the simple outcome is that groups in all three places, both women in South Africa as well as men who have sex with men in Bangkok and in New York, were able to use daily oral PrEP. We saw very high proportions of PrEP users achieving drug levels that have been associated with protection in the past. And so that was the good news. PrEP is something that people can use. Now, the recommendation for daily dosing was preferred by women in Africa. They thought it was simpler, and it didn't require that they plan for sex, which is challenging.
It was more schedulable. They were always used to habit.
That's right.
Every day.
That's right. You can build a habit around it. It provides the highest concentrations of drugs in the blood. It provides the most forgiveness for occasional missed doses. But one finding that was very important is that the men who have sex with men and Thai women in Bangkok were able to use the non-daily regimens as well as the daily regimens, particularly when the regimen was involved once a week dosing with a post-sex booster dose. And that kind of non-daily regimen was attractive to many men who had sex less frequently.
So, and Susan Bookbinder called it the seasons of love or sex or whatever it is, but this is another approach which you didn't investigate, but you could, that would be another thought to the way you might be able to use it.
That's exactly right. We know that PrEP is not for life. PrEP is only for people who want it and only for people in periods of time where they might be exposed to HIV. And so we are calling these seasons of risk. And we can see that people move in and out of seasons of risk. In fact, there are no risky people. There's just us moving in and out of seasons of risk. And PrEP is for those seasons, for those times when, because of a breakup or because we're moving to a new town or because of some change in our life, we're going to go through a period where we're having more partners, or we're not able to use condoms, or we're just not taking care of ourselves as well as before in terms of condom use. PrEP is for those times, and they will get us through those times if used HIV-free, so that we can get to the other end and be able to take care of ourselves in a relationship or with some other strategy.
And the side effects, minimal as they are, we're seen at either whenever they started it, whether they started twice weekly or whether it was daily, it didn't make any difference. But what about if there was the seasons where you would just say start it, just be it this month and maybe not next month? Would there be that startup again, do you suppose, or not? Or do we not know that?
As nearly as we can tell, the side effects that people have are mild, and they don't require, they don't lead people to stop taking the drug. They're able to get through them. And they occur in the first few weeks of PrEP use, really the first time PrEP is used. And so in people going on and off PrEP, we don't see them have those side effects again. But I would say that we need more information about that, and everyone's going to be different. And so, you know, we want to learn from people using PrEP about you know, whether the startup syndrome occurs the second time they start PrEP.
Now, it seems, and we talked about this, as becoming, I don't know whether we use the term trendy, but it seems as though that's what's happening. There's a trend towards becoming aware of PrEP. It's becoming more on Craigslist and on a number of other dating sites. People are saying, I am undetectable, or I am also being treated with PrEP, and I'm, you know, you know, I feel like I'm comfortable. There is the issue, of course, still with other STDs, but it seems as though this is something that is catching on. And how do you see is there a missing link in some of the preparation or education messages, or where do you see we need to go beyond where we're at now? What education needs to happen?
Well, I think it really depends on the audience. We are seeing in San Francisco and New York and other urban centers in the United States that PrEP use is expanding rapidly. In San Francisco at the end of 2014, we saw that 10 to 15% of gay and bisexual men were already on PrEP, and women were using it too for safer conception and to feel safer in their relationship. So men and women in San Francisco and New York and other places are picking up PrEP, and they're using it really on a large scale. But in other cities, people don't know about it yet, and they don't know who is able to provide it. And so I think one thing that we can do that really will help is to make visible the healthcare providers in our communities who are willing to provide PrEP in a culturally competent, humble way. And this has been the major barrier to PrEP. People hear about it, they want to try it, they go to a doctor and they say, I want PrEP, and they're told, no, you should be more responsible, it doesn't work, or they're given misinformation because the provider has not informed themselves. And so what we need is to make visible a list of PrEP providers who've taken the time to train themselves what's true about PrEP, how to write the prescription, how to monitor it. They've learned, how to make it as safe as it can possibly be. And they can learn that, it's not for people's whole lives. It's only for these seasons of risk where people move, into a situation where they might be exposed to HIV. So we need PrEP providers lists. Now there is one in California. It's called pleaseprepme.org, and it's a list that aspires to be comprehensive of everyone who's willing to provide PrEP in a culturally competent and humble way. But we need that across the United States, and we need it across the world. And so in other places of the world, people still have not heard of PrEP. I just saw data from Southeast Asia. Less than 10% of people who would benefit from PrEP have even heard of the concept. And so, in the United States, I think more and more people have heard of it, but outside the United States, it's still... Or
in small bedroom communities across the country are where it may be not as great a risk, but it's still, for those people who are trying to, or who are having casual sex, or more frequent sex, it is imperative that they become aware of this as an option.
I think and I think that's exactly what it is. It's an option. It's a choice that people can use. There are many ways that we can protect ourselves from acquiring HIV. We can use condoms consistently. We can negotiate safety within a relationship. We can make sure that our HIV positive partners are treated and that their viral load is low, and we can use PrEP. But there's lots of options. I just want everyone to think about, how am I going to protect myself, and whether PrEP has a role in that. And I think that's really important.
We really have answered, I guess, from the panel or the press conference this morning, all the people there. Really, that was a great panel, by the way. It was just a great comprehensive panel, except for the fact that there was no economist on there. So
there was no economist, yeah.
But it is the idea that we are at a point where we can actually say, okay, it's done. The science is done. Or is it? Is there something that's missing?
The science is never done.
No.
And it's not real until it's real for people. And I believe that science is democratic, and what's true is true because everyone can see it and feel it and use it. And so the science is not done. We're in a phase now where we need to learn from doing. And that is a full collaboration with PrEP users, people who want to consider PrEP but choose not to use it, people who are seeking treatment. I mean, I think we need to engage in a public science project where we see to what extent these different technologies can be adapted for people's lives in acceptable and attractive ways, and to see what people do with these opportunities. And then finally, we need to see this epidemic end in terms of zero HIV transmissions, and I think if we can broaden responsibility for ending it and involve everyone, whether they're HIV positive or negative, in that struggle against HIV, we will see it end. But that is a project, and it's a project that is more collaborative than anything we've ever done before. And I think we need to rise to that task. The science is not done.
I know Myron Cohn said 90, 90, 90, and maybe another 90 for prevention, because it really, and maybe 96, because you got that. It seems like prevention really is, it's amazing the results of these trials.
Yes.
They're absolutely profoundly effective.
Yeah.
And almost to a perfection. But like you say, unless it's, the last piece of it is getting out to the community, getting the education going. It's a critical piece of it.
It's a critical piece, but I think we need to emphasize that these ideas came from the community. We don't, I think I like to think of myself as the midwife for PrEP. I didn't create the idea. I didn't step up and participate in the trials. I led them, but I didn't participate in them. And so the community gets credit for having created the knowledge about treatment as prevention and PrEP. And so we're not giving back anything to the community. What we're doing is engaging in a further collaboration that leads to actually using what we now know works. And if we can use it, then this epidemic will end.
Yes. Thank you so much, Bob.
Thank you, Fred.
Appreciate it.
Yeah.